Hi, so welcome everybody to day 2 of London Global Cancer Week. I'm completely delighted that AORTIC are hosting this session. Thank you very much to Julie and to Nazik for pulling together such a fabulous array of speakers whom we're all really looking forward to hearing about on this important topic. And with that, I'd like to hand over to Cecil Tina.
Hi, good afternoon, good morning, good evening to all our colleagues join us from across the world. It is an honor to welcome you to this important section of the London Global Cancer Week 2025, dedicated to a topic that sits at the very heart of our AORTIC mission, cancer care in conflict zones in Africa. Today, we shine a light on the realities faced by millions of people living in countries affected by conflict, climate injustice, and forced displacement. In our continent alone, over 40 million people are uprooted from their home. For them, accessing cancer care is not only a health challenge, it is a question of survival. As AORTIC president, I am immensely proud of the work of our special interest group on cancer care in Africa affected by conflict, led with dedication by Nazik Hamad. This group continually reminds us that delivering cancer care in such an environment requires not only clinical expertise, but also resilience, innovation, and deep compassion. We are privileged today to be joined by outstanding speakers, clinicians, researchers, advocates, and practitioners who work on the front line in those countries. And they will speak about the collapse of the health system and the conflicts to immobility of patients under displacement, the trauma affecting young people and the family, the extraordinary creative of health workers who continue to deliver cancer despite all odds. Also, I'd like to thank Julie, Susie, Richard for your leadership, and thank you all, our speakers. Thank you to bring your expertise, your experience, and your courage to this global stage. I hope today's conversation will energize collective action and deepen the global commitment to ensure that no African patient is left behind regardless of where they live or what crises surround them. Thank you for bringing here, and I look forward to a rich and impactful discussion. Thank you.
Thank you so much, Ceciltina, and congratulations on becoming AORTIC president for the next 2 years. So I think you've covered most of the points I wanted to make, but it is a pleasure as VP, Vice President Europe for AORTIC, sitting for a second term to make some opening remarks. I just also want to applaud the work of the Special Interest Group, firstly raising this issue on the global stage, but I'm looking forward to some outputs of the group so we can work together as advocates to raise the profile of this issue in Africa. You know, I think I can just open or reiterate that humble statistic that Ceciltina's already shared. By the end of 2024, 123.2 million people were forcibly displaced from their homes and livelihoods. Africa is a continent with the largest population of people that are forcibly displaced, at 43% of this total. So 530,000 people and families being forcibly displaced from where they live. At least for some of those in refugee camps, we are starting to see some more organised cancer care and provision of the most important prevention services like HPV vaccination to prevent cervical cancer. But this is not the case for the majority of the 530,000 people across our continent, So I hand over to our chairs, Dr. Nazig Kamand and Professor Richard Sullivan, to walk us through some country dispatches and show us how we may be improving a little bit, but also the gap and where we need to advocate for more political attention. I hand over to our co-chairs.
Thank you so much. I will have Richard introduce the next speaker, but as chair of the SIG, I want to thank Susie and everyone. And this SIG started 2 years ago. We have accomplished a lot, but there's so much that we need to do. So I'm hoping all of you will join us and help push our work forward. So I'll hand it over to Richard.
Nazig, thank you very much indeed. And may I just firstly recognise your amazing leadership of this group and to everyone on today, and to thank the new AORTIC president for those fantastic opening remarks. So it's a great pleasure to introduce our first speaker in what's going to be, I think, a fabulous panel that we've got ahead of you. And really exciting, we're going to be talking about cancer surgery to open up with, which is often completely forgotten in this dialogue. And it's a real pleasure to welcome Abdul Halim to talk about cancer surgery and prevention in Burkina Faso, a country, of course, which is right in the eye of the storm. So, Dr. Halim, over to you, please.
Hello, thank you to all of you. Thanks for this honor that allowing me to show to talk about this topic, firstly in Tunis, and secondly in this great meeting. I'm talking about the London Global Cancer Week. So if it is possible, I can start. I will start with the first one. It will be about cancer prevention in Burkina Faso.
Could you
Yes?
please put it in slideshow mode, if you can?
Yes, of course.
Excellent. Thank you so much.
You're welcome. Then I have to do two presentations. The first one is initially for Dr. Samir Tudrago, and the second one is mine. The topic will be about cancer in conflict zone. So first of all, it is known that in Burkina Faso we are faced to many challenges such as insecurity and terrorism attack. All these events have some impact in our country, so that you can see that in this slide we had all the northern of the country, the red zone, is where we can have the 200, more than 400 health facilities were closed, and some of many people, such as 2 million, were affected by this event. And first in our country, since 2015, there are laws that our government takes about cervical cancer prevention and also breast cancer prevention. Then cervical cancer prevention and precancerous lesion detection was free of charge. And since the 2022, the mammography is also free of charge. That's what that we can have about breast and cervical cancer prevention. But what we had in order to treat cancer in Burkina Faso is in the principal two cities, Ouagadougou and Bobo-Dioulasso, where we can have radiotherapy facilities. Chemotherapy is available in Bobo-Dioulasso, Ouagadougou, Waiguia, and also Fatangurma. Then in these 4 cities in our country, only in these cities that we can have cancer facilities. Then the other region have to come to this city in order to have some treatment. Dr. Samuel Eto's team performed a study. This we are in this country. They are talking about the internally displaced women. Then the people who are survived are a mean age of 34. These people need psychological support more than 60, and out of them, most of them are difficulties for accessing health services. But all these people, they never heard about cancer prevention and cancer treatment. Then our government, the Ministry of Health, provides 15 mobile clinics across the region. And these clinical mobile, we can see like facilities, installation for breast cancer prevention and cervical cancer prevention facilities. All these mean in order to prevent cancer is free of charge. Then since 2022 in Burkina Faso, mammography and also cervical cancer detection is free of charge. Then the Ministry of Health provide these clinical mobile that can reach in all the part of the country. And we hope that with these mobile clinics, we can reach many people and trying to improve outcomes in cancer prevention in Burkina Faso. Also, we are doing sensitizing people, and also we are organizing screening campaign in Burkina Faso's cities. This is about kayas, and also we are doing outreaching to touch most of people, internally displaced people, and also those who can't come to the cities in order to benefit from cervical or breast or another cancer prevention. Then more than 2,000 people was reached directly, and about 400 women screened in 3 days by these screening campaigns. And we hope that with these means, we can reach in the region of our country that was exposed to insecurity and terrorist attack. So all these, the team that conducted the studies was about the group d'Action contre le Cancer and the chair REACT, and also the University of Joseph Kizerbo. And this is about how we do in cancer prevention in Burkina Faso. And the second slide, if you allow me, I can continue with the one that about cancer treasury in conflict zones. Then first of all, cancer treasury in conflict zone, it means that how to manage surgical procedure for cancer patients in areas affected by conflicts, where we can see insecurity or political instability in this country. Then in Burkina Faso, we do this kind of surgery because since 2015, we are facing to this event that really had a great impact in our health system. The interest of this topic is about ethical, because when we are in the insecurity zone, the priority is not to cure planet disease like chronic disease, cancer, or kidney disease, or infectious disease. What we can have like emergency is about trauma surgery, because people because people coming is in emergencies, and our government take many decisions only for this kind of traumatism. The conflict effect on our health system is that most of our health facilities were simply destroyed or locked, especially facilities that we can find in the northern of our country and the eastern also in our country. All these facilities were simply locked. And most of the health workers were fleeced or simply overwhelmed because of the insecurity. And patients that live in this zone don't have they have more than one choice. They have to stay, and unfortunately, because they can't go to the big cities where they can find treatment, then they have to stay because in our locality, in our zones, there are no tools, and the disease have to progress, unfortunately. Then what we can have if the patient arrive in the security zones, we can find that they will come with advanced or metastatic disease. And the follow-up is interrupted because these patients can't come to the big cities or to regional cities in order to benefit from cancer care. Then they have to stay in order they have to stay if they want to live, because taking a risk to come for a simple cure is maybe fatal for them, or they can be kidnapped by terrorists. And most of our treatment means was about palliative treasury, or simply we can't give them no treatment because the disease is too advanced, then metastatic. This is an example that we found. It's about stage 4 breast cancer. It is an inflammatory breast cancer, and this is about a pancreatic carcinoma that which is responsible of jaundice. This is due to the biliary duct obstruction. So what we can do here is biliary duct derivation. That means a palliative surgery. The management challenges that we are facing is firstly ethical and also humanitarian. Then the NGOs present in our country, especially in the conflict zone, or managing only traumas people. There are no program or no project about cancer patient management. And what we decide to do is that if a patient comes first in our hospital, we are talking about how to do. We must do a radical surgery, because if you do the right indication, maybe this person will not be able to come after, because if you go back home, there will be no possibility for him to come maybe after 3 months or 1 year. So we are talking about giving to him a radical one. An example, a cancer in the hand, we have to maybe to do radical amputation of the arm. That faces us to the equity of the cancer care in our country. In the same country, two kinds of treatment because of insecurity. How it's possible? Then we are talking about this with our leaders, political leaders. We are showing them that most of the patients that we are taking care, if after the first surgical treatment, we're not sure that we must have them, we must see them after 1 year or after 6 months. So they decided to provide us mobile clinical or surgical unit. Then we use the same mobile clinical unit in order to do some outreach and to see some of them. But it is a cost because we must go in there with soldiers. Sometimes it's not easy. We are many incidents, but people are not available to go there because it is too risky. But and also we are talking about telemedicine in order to train people in the small health in the small health facilities. And also we are talking also about how to include cancer care in the emergency response framework. And what we are talking about is that we must build a resilient health system in order to take into account patients in conflict zone in our program, because we don't have choice. The situation, we don't know it will be end next year or after 5 years. So we have to be very resilient. Then it's my last slide that given to all of you. Thanks from my teams of Kaya's Regional Hospital. So thank you for your attention.
It's absolutely fantastic. Thank you so much for kicking us off so well. Nazik, I'll hand over to you to introduce the next speaker.
And just I want to thank Dr. Abdul Halim because he also gave the presentation that Dr. Samiratu, she's in transit. So thank you for that. And what I like is the real examples of what people are doing, resilience in the face of moral distress and, ethical issues. So we go next to, for the first time, also since AORTIC is, we go to one of the host countries. So Uganda is one of the hosts the largest numbers of refugees in Africa. And from the Uganda Cancer Institute, we bring the head of navigation, nurse Fatina, so to guide us through what happens to refugees and the future, plans to improve navigation for refugees. So Fatina, you go, and also if you could put it in slideshow mode. Thank you, Fatina.
Okay, good afternoon, good morning, everyone. Thank you, Dr. Nazik, and thank you, team. I'm sharing our experience, how we manage refugees, how we've been able to contain them, and then majorly I want to put to the globe the challenges faced by the refugees received in Uganda and those suffering in cancer. Cancer does not wait for peace, neither should cancer care. And therefore, these patients who suffer cancer and yet they're refugees, they are double disadvantaged. Like most of us have already said, Uganda hosts 1.8 million refugees. Last year, 1.7 million refugees were registered in Uganda. It costs $361 million to take care of these refugees. And this is not inclusive of the cancer care, which now I want to preach to the world to see how better we can improve their health. The Uganda Cancer Institute, a public oncology center and the East African Center of Excellence, receives approximately 300 to 400 refugees with cancer annually, and majorly from DR Congo, Southern Sudan, and then some come from Burundi. Most of the refugees come in late stages, and they are not able to spend a single penny upon their treatment. Despite being a public hospital, UCI cannot fully cater for supplementary treatment needs of cancer patients, that is transport, accommodation, feeding, and almost all of them are unable to pay even a single penny. Minus that, also they cannot approach, or it is hard for them to reach the UCI. UCI has a patient navigation program which takes care of all patients who come in here in terms of access to service points, knowledge of the diagnosis. But this is also cannot take care of the entire population. It only caters for 20%. And then when it comes to refugees who have even special needs, it's something which remains a big challenge. The challenges affecting these refugees have been categorized into three, and this is the model, the patient navigation services. One is physical access. They lack clarified guidelines or guidance to the UCI from their camps. We have a disconnect between us, the oncologists here, and then the people who diagnose these patients and those who refer them. So it's a very big challenge. They also, when they reach here, because of language barrier, they lack clear traces to the different service points. Also, another category of challenges is clinical navigation, where they lack awareness and access to timely diagnosis. They always come very late. They have limited access to treatment and literacy about their diagnosis. There's inadequate referral discharge system. There's no follow-up. We do not know what happens pre and after treatment. The refugees have pre-existing trauma psychologically, and when it comes into cancer, they have a lot of psychosocial barriers, emotional traumas, which affect their outcomes of care. They also have limited, or some of them, we do not have enough information about the lived experiences of these refugees. As I've said, we take care of them, but there's yet not much information of how do they access care here, what do they go through. Also, they have informal navigation. They come into UCI by different individuals, by themselves. So we cannot ask much when they reach here. Another category is resource navigation, finances. They are unable to meet the costs. As I said, we are a public institution, but there are costs which are done outside the institute, like the cancer of the breast. Some patients will need to do, all patients will have to do the ECG echo. And these patients will have to move out of UCI to go to the Heart Institute, which it will have, they will need to pay, and they do not have any single penny with them. Accommodation, transport. We all know that the nature of cancer care requires a patient to frequently visit the institute and also visit different specialists. But these patients do not have where to sleep while they are here for treatment. They also lack family and social support. Worst of all, when we have them pass on, the repatriation of their bodies becomes a big challenge. As I referred to one of the clients we managed this year, was a 45 female, CS cervix, was brought in by the daughter. And they told us that somebody just directed them to board a bus and come here. So when they reached there, wherever I could ask them to at least meet any course, the daughter could just cry. So later, the navigation team available on the ground became their relatives. They stayed in the care home. The care home is a place where we went in at the UCI. Can you hear me? Okay.
Yes,
Yeah.
please.
So they stayed there, and because she came in later stages, she was later admitted in our ward where she spent a few days and she passed on. It was very touching because we could run everywhere, but we could not get any support. As a model of care, the patient navigation program has been implemented at the UCI since 2021 and has proven to be a mode of care that can support patients in the three folds I've already explained. As we can see, the studies done, we first did a baseline study and then we did 2 annual surveys following the implementation, and it proved to have significantly improved patients' experience. It has physical navigation. As I said, the physical barriers, we would have people who link us to these patients. We have ambulances. We organize them even before they reach here. And when they reach here, we have people who speak their languages. We all know that as a country is being displaced, some of them are professionals. So in the refugee camp, there are doctors, there are nurses. So some of them can be brought on board to support these patients as they are moving through care. But also if we have many other navigators who can support them. The clinical navigation arm is used to educate patients, as we can see, to educate patients on their diagnosis, clear their myths, refute any unnecessary information, give them psychosocial support. And then the resource navigation, the UCI has a care home where we keep these patients. But we also think that for the refugee, it can be a better modernized place where they can sleep. Because for our patients who sleep in these living tents, for them, we know that when they are here for 2-3 days, then they will turn home, then come back. It means for a refugee, once they come in care, at least they should be here for the active treatment, maybe 2 to 3 weeks when they are here completely taken care of to make sure they go through care. What are future directions which we can guide as Uganda? We need the research initiatives to understand the specific needs and experiences of these refugees, because as I mentioned, we do not have enough data to explain what really takes place in the journey of these cancer patients. We also need a specific patient navigation program which takes care of deep needs of these refugees, psychologically, socially, and the language barrier. If we can pick people who have been already in the practice to be brought on board, be oriented, and they support in the care of these patients. We will also need to monitor and evaluate the implementations and know how much have we been able to lift the burden. Also capacity building, training health workers, both where these refugees come from and where they are coming, such that we can know what happens underway, what happens before, what happens after. The follow-ups are also very, very, very important. As I conclude, refugees need a culturally congruent care package, inclusive of individualized social support, from diagnosis survivorship for a better cancer care outcome, and an integrated navigation program approach which combines awareness, individualized support, and policy changes. It's very important. Developing, implementing, and successful culturally sensitive navigation calls for evidence through studies on lived experiences of refugees accessing care. Also, lastly, fostering collaboration among healthcare providers, policymakers, and is also very vital to enhance the quality of cancer care rendered to refugee patients. I want to thank you all for attending this meeting. I thank AORTIC, American Consultant, because they gave us a mode of the navigation, which is really good and we trust it to solve these barriers which are affecting patients. I thank the UCI management, the navigation team on the ground. Thank you very much.
Absolutely wonderful. Really, really fabulous. Thoroughly enjoyed your lecture in aortic in Tunis, and even better the second time round. And I think sort of just highlights, and this is going to be a recurrent theme about the issues around cancer care and refugees. And I know we'll hear a little bit more about that in a moment from Malawi. But first, it's my great pleasure to call to the floor a very medical oncologist, Dr. Sidibe, from Mali, who's going to talk about the situation for cancer care in Mali. And obviously, it's a highly complex, conflict-impacted ecosystem. Dr. Sidibe, the floor is yours.
Thank you, Mr. Sullivan. Hello, everybody. I try to share my slide.
Yeah, so Belmira,
Belmira, is okay?
They will share it soon.
Okay.
Slideshow.
Thank you.
It's great.
Okay. Hello again. I'm Dr. Sidibe from Mali. I'm very happy to present today again cancer and conflict in Mali. Slide, please.
Next slide.
Next slide. Oh. Slide. Next. Next. Okay. Good. Mali is a big country located in sub-Saharan Africa. There are various ethnics and religions which with people live together in perfect harmony, and population are around 24 million. And next slide, please. Since 2012, there was a ethnic conflict in Mali with many terrorist attacks in north to center of Mali. So with consequences, insecurity, the refugees and displaced people in neighboring regions or countries. And for health, there are main consequence was decreases in budget. Next. So for cancer management in Mali, next. Cancer management is only provided in Bamako, unfortunately, and in only 6 university hospitals with some private clinics. So for people who live in north or center of Mali, it's mandatory for them to go to Bamako for cancer management. Next. Next, please. So, since conflicts, our major problem were decrease in healthcare budget. For example, in 2012, healthcare budget was 8% for state budget, and now in 2025 it's only 5%. Contrary for security and defense budget, there are very increasing in 2025. So it was 7% in 2012, and now it's 25%. In parallel, cancer and other chronic pathologies are very increased. For example, according to Global Cancer, in 2012, in cancer incidence in Mali was 14,100 to 2025, it's 17,000. Mortality is again increased. Next. So, the major difficulties for people who live in conflict area in Mali was first traveling. It's very difficult to lift par exemple, Tombouctou to go to Bamako because there are insecurity, terrorist checkpoint attacks. The road is very poor and the cost for traveling is very expensive. Second major problem were the departure for NGO. Many NGO left Bamako because insecurity. So we are over consequences in cancer care management, like very delayed in diagnostic and treatment waiving. So morbidity and mortality of cancer increase too. Next, please. Next slide. So to conclude, there are in Mali, in Africa, there are inequity differences in cancer care between LIMIC and how a common country. So to avoid inequity between Malian, to avoid inequity between Malian people, we need to find grant to do study in epidemiological on impact of a conflict on cancer, and we need to create cancer care management in conflict area, to develop telemedicine between conflict area in Bamako or other countries, and to create also humanitarian corridor and drug logistics for these people. So I hope next year we can do that, because Malians, it's one people and one objective. Next. Thank you for your attention. Un peuple, un but, une foi, like one people, one goal, one faith. An acknowledgement of all Malian healthcare professionals, patients and family, and our soldiers, and one NGO which stay with us since conflict. Thank you.
Dr. Sidibe, merci, c'était formidable. I mean, wonderful lecture. And I think some really shocking data showing how much money is going to defense compared to healthcare. And just to give you a sense, something you don't realize, and most of you will, Mali is twice the size of Texas, 1.3 million square kilometers cubed. So lots of issues there to unpack. At this point, I'm going to now turn over to our next speaker. And as I promised, more discussion on refugees, this time in Malawi. And it's a great pleasure to welcome to the floor another medical oncologist, consultant medical oncologist from Malawi, Dr. Precious Makondi. Dr. Makondi, the floor is yours, please.
Slideshow on the next animation.
That's it.
Oh, okay. Great.
Greetings once again. So my name is Precious Makondi from Malawi. So I'll talk about Dzaleka refugee camp, which is the only refugee camp in Malawi. The situation with Malawi is we receive displaced people from neighboring countries and also from other countries across Africa. So Dzaleka refugee camp is situated in Doa district, which is about 40 kilometers from the capital city of Malawi, which is Lilongwe. And also Lilongwe is where there is the largest referral hospital in Malawi, Kamu Central Hospital, and also the only public cancer treatment center, the National Cancer Center. So it was opened in 1994 for 10,000 displaced people, but currently it hosts over 56,000 people, which are mostly from Democratic Republic of Congo, Burundi, Rwanda, Sudan, Ethiopia, and Somalia. So with this, there is overcrowding in the camp, poor sanitation, and also opportunities are very limited, which are in education and employment. So the people in the camp and also around the camp and the communities alike, they access their health services at the Dzaleka Health Center, which is fully owned by the government, but it also receives support from the UNHCR. So the people, when they have symptoms and complaints, they go to Dzaleka Health Center, and Dzaleka Health Center, if they are suspecting cancer or any major ailment, they refer them to Doa District Hospital, the district hospital. So from Doa District Hospital, the patient are normally referred to Kamuzu Central Hospital or the National Cancer Center to receive the care. So with this pathway, there are many challenges when a person is diagnosed of cancer or has cancer. The challenges include this delayed diagnosis, as you can see, the referral pathway, how it is. And also, most of the people who are in the camp, they don't speak the local language or English. So there is language barriers and communication gaps. And also because the health center normally doesn't track those referred to the district hospital or the National Cancer Center or the central hospital, there is challenge in record keeping. And also we don't have patient navigation systems in our cancer care. So because of this, we have missed appointments and also care discontinuation in people who are diagnosed with cancer. And also we have lost to follow up, and in the end, inadequate supportive care. And also, apart from this, there are some barriers to care in people who are displaced in Malawi and living in Dzaleka refugee camps. Some of these are like there's limited financial support. They report that they receive $5 per day, but some even say that it may be lesser than $5 per day. This leads to them to not be able to afford diagnostic tests and also follow-up care. And also it has been noted that people in the camp or around the camp are generally, they delay in seeking medical attention. And also from other factors, the misinterpretation of symptoms also, and also there's heavy adherence to treatment. And also due to other reasons I've already mentioned, the difficulties in transport, and there are also some challenges. The hospital and the health center doesn't provide transport to the people in the camp or around, and due to distance and cost, there's always transport difficulties. So from this, I think we need to call to action. This is best worked through collaborative effort. We need to improve cancer care at Dzaleka refugee camp, mainly through a multi-stakeholder approach. So calling the Ministry of Health, UNHCR, the other stakeholders, which provide services to the refugee camps, health center authorities, communities around the camp, the district hospital, Kamu Central Hospital, and the National Cancer Center. And the specific solutions which are proposed is we need to have a proper cancer care coordination team. We need to develop a referral pathway and a tracking system. We should have a patient navigation and support services. And also around the camp and the community, we need to enhance health education and awareness. And above all, we need to strengthen that data collection and also analysis. Yeah, so that's all from Malawi. Thank you.
Thank you so much, Precious. I think it's great that we heard from host countries, actually, probably for the first time in these sessions. So we now move to another setting in what I would call post-conflict, or at least a sort of recovery. So we know South Sudan has been embroiled in a lot of conflicts through the years, and maybe they're not all over, but it's really my pleasure to introduce Dr. Iduro Ojukwu to tell us about cervical cancer management in South Sudan. Again, this is another example of a fragile health system that are living in a post-conflict, and still some elements of conflict are affecting them. So, Iduro, please go ahead.
Okay, thank you, Nazik, the introduction. I think you have just introduced that we are post-conflict or recovery, but we are ongoing conflict. So we have not recovered. We are still ongoing. Yeah, so I will basically be presenting on what we have done in terms of cervical cancer screening, because that is my area. I'm a gynecological oncologist. Cervical cancer screening program was never there in South Sudan. And we all know that cervical cancer is the leading cause of cancer-related deaths among women in sub-Saharan Africa. And the data speaks for itself. As all of us know, more than 600,000 new cases annually, and actually more than 300,000 deaths which occur annually in sub-Saharan Africa. And as WHO has envisioned an elimination plan to achieve a threshold of 4 per 100,000 women, I think South Sudan is still very, very far from achieving any of the goals, especially when we come to the 90, 70, 90 targets. I can still say in terms of screening, yes, we have started, but in terms of vaccination, no, in terms of treatment, still we have a long way to go. So estimate from GlobalCan in 2022 reported that we have more than 740 cases that year of cervical cancer, which actually accounted for 18.6% of all female cancers and 10.9% of all newly diagnosed cancers during that year. And predominantly, all our cases come in late stage. So what have we done in terms of cervical cancer screening? So far, the Ministry of Health have established a National Cancer Control Department at the ministry level, which has actually just been established mid this year. At least this is a progress. And in terms of cervical cancer itself, we have managed to develop guidelines for cervical cancer screening and treatment of pre-malignant lesion, which actually was done late 2024. That was in October. But still, the guideline has not yet been fully endorsed by the Ministry of Health. We are waiting. We had some issues at the ministry level, change in leadership now and then. So at least for now, we have a minister for the last 4 months or 6 months. So maybe our guidelines will be endorsed soon. And in terms of healthcare providers, we have trained around 40 healthcare providers to be established at the screening sites for cervical cancer screening. But we only established 5 screening sites in South Sudan, and unfortunately, most of the screening sites are located in Juba, which is the capital of South Sudan. When I say the screening site, I mean the public screening sites. And only one is in a state called Western Bahr al-Ghazal, and that is, the capital is Wow. And from the data that we have collected for the whole 1 year, we found out that precancerous lesions account for 6.5% and invasive cancers 1.6% of our cases. So these are some of the facilities that we have established. They look great and nice, but maintenance is a problem. So so far what we are using is VIA. I know most of the countries have moved away from VIA, but still that is what we are using due to the low cost and availability. Pap smear mainly happens in the private facilities. Again, it is expensive, and most of the patients cannot pay for they cannot pay for the cytology to be done because also the cost is too high. And we have thermocoagulators that we use for the treatment of premalignant lesions. And unfortunately, we only have 2 thermocoagulators. One is in the whole of Juba, and one is in Wow. So we still a long way to go. HPV DNA testing, non-existent even in the private facilities so far. We don't have. And HPV vaccination, as we know, it offers prevention for cervical cancer as proved by many studies. But in South Sudan, there is no HPV vaccination program in place, and it's still at the private facilities. I don't think affordability is also a problem. But in our guidelines, we actually included and we recommended HPV vaccination as for other countries to be given to school-going girls, which is 9 to 14 years. We have so many challenges, but what strikes out is infrastructure and access. Like I said, most of our screening facilities are located within the urban areas, so accessing it by most of the population is really very straining. And again, like I said, we have limited rollout of national screening programs. Also, we have cultural barriers and so many myths and misconceptions surrounding cervical cancer and cancer in general exist in South Sudan. I think we have a long way to go to really make our population understand about cancer and specifically cervical cancer. Financial challenges stand out. There is high poverty levels in South Sudan, and a majority of the women depend on out-of-pocket payments for health services. We don't have government funding for cancer prevention and treatment. So transport consultation is also a big problem. And this results in delayed screening and diagnosis, late stage presentation, and increased mortality due to cervical cancer. So although in the public settings and a screening program that has so far been established, it is free of charge. Even the treatment of premalignant lesions are free of charge. But then when it comes to advanced surgery, the public facilities not well equipped. So most the surgeries referred to private facilities, which is also expensive for the patients. Chemotherapy in public facilities was not there, but so far we have started for the gynecological cancers, and still the cost is like $200 per cycle, which is again expensive for the population of South Sudan. Radiotherapy is not available, so we refer our patients to Uganda, Kenya, and we used to refer to Sudan, but now we have this conflict. Like one of the presenters have said, majority of our patients actually prefer Uganda, but then again, they go with nothing because they actually have nothing. So a woman from rural South Sudan actually spends more on transportation than the actual screening that they are looking for. So some of the strategies that we are putting in place to reduce financial barriers to extend the free screening and treatment programs, and we are looking at government subsidies for treatment of diagnosed cancers. And we need to integrate more cervical cancer screening services into our primary health care. And also partnership with non-governmental organizations and international donors. So somebody has presented about mobile clinics, and I was so impressed. And we don't even have one. From the many trucks for mobile clinics that you have in Burkina Faso, maybe you can donate one to South Sudan. Yeah, so we are looking at opportunities to support to roll out HPV vaccination program in schools. Work is ongoing, and also we are collecting our data to track progress and target intervention. So also ongoing talks are going with neighboring countries to see how they can help us in HPV DNA testing, so that also we can move with the rest of the world. And also we are looking on how to improve our diagnostic and treatment infrastructure. So this result in delayed care, advanced disease, and a lot of preventable deaths that happen. So our recommendation is we need to expand screening coverage, introduction of HPV testing and HPV vaccinations, then how to engage community and cultural engagements with our traditional and religious leaders. So we need to also improve on our awareness outreaches. So we are still advocating for HPV vaccination. And if we have donors who can come in and help us so that we can scale our chemotherapy administration to our women in South Sudan, that will also be highly welcome. So we have many stories, but because of time, I think I will just end here and say shukran.
Outstanding. Thank you so much. It's just been great to hear from South Sudan and to know that a lot is being done. And so now we will move to Dr. Sarah Abdul Jalil, who is a friend. And I met Sarah, was from Sudan, but she is the one who introduced me to the Sudan Doctors for Peace and Development. And I had a chance to visit Uganda and meet Fatina, and also follow some of our cancer patients who are there. And we would like Sarah to talk to us. She's actually an allergy and immunology specialist in London, and we would like her to talk to us about diaspora engagement during conflicts.
Thank you very much. I hope you can hear me well. Thank you, Professor Hamad and the AORTIC team. I can see there are quite a few colleagues in the call. Can you hear me well? I'm just worried about the NHS equipment.
We can hear you, Sarah. Hi.
Yeah, I'm from Norwich, not London, because I can see some colleagues from London. And thank you very much for the opportunity and hearing from other colleagues from other parts of Africa. So as the IOM describe us as diaspora, and I have never met an African who's not a diaspora, the definition that we are the immigrants who are connected to our country of origin as well as our country of settlement. So if you're not keen and connected to your country of origin, you're not a diaspora. And therefore, I think we have all been connected. We are all diaspora. I'm going to focus on Sudan, although I've worked with other countries in conflict, as I come from Sudan. And in the last 3 years almost, we have been, supporting with ongoing needs. So the focus will not be only on medical diaspora, but at the beginning of the conflict in Sudan, there has been a conflict ongoing for years and years. But since April 2023, the expansion of this conflict, the diaspora played an important role in even evacuation and safe passages for the civilians who were trapped in the high violence areas, as well as providing health access remotely, because civilians were trapped. They were facing a lot of challenges, and they were killed even if they were seeking medical sort of care, as we have heard about a lot of sad stories. A pregnant woman in labor who went to hospital to give birth, and she was shot and killed in front of the hospital. Most of this work was advice and guidance, listen and trying to sort the care of these civilians within neighborhoods where it's safe, so that they are not moving around and they are not killed during the violence. And the work was mainly by crowdfunding and fundraising. This diaspora usually are the first to respond together with the mutual aid groups on the ground. And in Sudan, we have proved that we were the first to step in while the international community was paralyzed and continued to be paralyzed and able to act appropriately. Another aspect is the medical education during conflict, which is underestimated, and it can be an important humanitarian response tool. And we have shown that by maintaining medical education in emergency remotely and by simulation-based education, that there has been a lot of work that has been done, because at the end you will have isolated groups of health professionals, whether they are medical or nurses, a pharmacist, who will form a group like a neighborhood group, and they will be the one who is serving the civilian within that area. And therefore focusing on emergencies, outbreaks, and even NCDs was really important, because there was no way for the civilians to move around. During our work in 2023, we led a crisis coordination unit, and that was trying to help the mutual aid groups, the donors. And as a diaspora, you understand your country, you understand the context, you understand the challenges. And we were successful. There was a bit of, sort of surprise, or how did you know that? But this is our country. This is where we know where are the needs, and we can quickly establish the network. However, the diaspora are under-recognized, their work is not well identified, and in some institutions, they are not even welcomed, and they are only considered as a source of remittances. This work always will not be successful without partnership. And this is the photo on the right with Professor Hamad recently when we were in Sita in Uganda. And in this work, there are different diaspora individuals and groups who came together to raise these sort of health and well-being campaigns, where we provide, or we try to provide, an integrated model. And the visit of Professor Hamad at that time, Nazik, for patients with oncology made a huge difference about advice, about guidance, about reassurance. As some colleagues mentioned, there is a language barrier, there are cultural barriers, and therefore to have a Sudanese who can speak to you in your language and explain the pathway and understand the referral for several or most of the patient was what they needed. And the collaboration is really important between the host community. We are grateful for those who are now looking after Sudanese, especially in Uganda. We had a very, successful story between the diaspora and between the local community, where there are health committees to identify their needs. The other role that the diaspora will play is advocacy. And this is really important. Advocacy for healthcare, for access, advocacy for human rights. I'm a pediatrician, so I work a lot in advocacy for children. We had the Adolescent Health Corner. We distributed menstrual cycle pads and dignity pads, and we have delivered that in schools in Kiriandengo in the north of Uganda. And that's for not only Sudanese, for Sudanese and non-Sudanese girls under the age of 18. And I think that's really important that we should work together, because the effect of conflict, whether it is in Sudan or in other country, the impact is the same on civilians. And this is what we should be aiming to help and support. So the work of the diaspora is transnational. When I'm talking about Sudanese diaspora, it's not only the UK, it's worldwide now. And, you know, each of the diaspora group will bring their own expertise. And we have to realize that the diaspora are diverse. We are not all similar, even if we are Sudanese or we are from another country. And it is intergenerational. I am a first generation diaspora, but the second and the third generation as well are playing a major role. So I talked about the Adolescent Health Corner, and this was an interprofessional engagement. So we had Sudanese who have been working in social services, we had legal advisors, we had doctors, and this combination of health and social care was really important, because it's not just about distributing the pads, it's about talking about sexual violence, it's about talking about protection, about harassment, about FGM, about childhood, marriages and all of that. The intergenerational diaspora, and allow me here to use my own family, my son, raising funds for education for children in Sudan. And that's really important, because we do not have equity to international humanitarian support. And I say that really when I'm really very sad about that. I live in the UK, the same access that other colleagues who have a conflict in Syria or Afghanistan or Ukraine or in Gaza is not equivalent. We could not get the support, for example, from Med UK to be deployed, to go with our own money to help our people. And therefore, there has to be an equity even to the international humanitarian support, because we are all human and we are all suffering if there is a conflict, and there is no difference between one country and the other. At the moment, we are working together for the NCDs with the local refugee health committees. One of them is the rapid response team. We're going to work in Uganda, and that is looking at a team that has got a midwife, medical officer, a nurse, a dental team, as well as a mental health sort of specialist. And the training has been established. I have realized that has been a lot of work that has to be done around allergies, about asthma, allergic rhinitis, allergic conjunctivitis. And so training the local team, so they are the one who are on the ground, and they are to help the the patients, and to make sure that there is compliance with medication. They know the referral pathway. There is no delay, in accessing health services. In addition, as diaspora team, we are building networks and connections with different colleagues and exchanging knowledges and making sure that there is an integrated health model. We are providing by Sudan Doctors for Peace and Development, and I think a very exciting model where there is dental health as well support for refugees and for the host community. I would like to end by saying that whenever there is a conflict and there is work, children are always left behind. And the suffering of children during conflict, for example, in Sudan until now, documentation for that, whether they are inside Sudan or refugees, is not complete. And therefore, we established the safe spaces for tiny steps where children will be offered a safe space for different activities, and those who are identified because of any issues psychologically related to trauma and conflict to find the appropriate pathway so they can be supported. There is a lot to be said, but I will stop here. Thank you.
Richard.
Yeah, wonderful. Sorry, absolutely superb. Just to echo Julie's comments as well on this is to hear about the advocacy and the importance here. the diaspora, I think, is crucial. And I think we often get caught up in the technical aspects of cancer care and conflict without, as you so brilliantly articulated, the wider issues. So thank you so much for a superb presentation. And very last, but by absolutely no means least, it's wonderful to welcome Dr. Iman Ahmed to talk to us a little bit about broader NCD care in refugees. This will be the last talk before we go into the panel session. So over to you. The floor is yours.
Thank you very much, Dr. Richard, and thank you, Nazik, and everyone for organizing this. I'm really delighted to be with you today. This has a special place in my heart. I am a medical doctor specializing in public health, and I also specialize in migration and refugee studies. So it's really remarkable to be part of such important work, especially around cancer, because it continued to be the blind spot for decades. So this is great. Now I'll start with my presentation. So the content of the presentation is I will talk about NCD care and then zoom out to present the findings of a study that we conducted this year around cancer care for refugees and displaced communities in Africa. So I thought of starting with the NCD umbrella because the umbrella is very wide and it covers various categories of NCDs, yet still there are specificities that we need to pay attention to and bring along with us to the table when talking about any of the categories and the other. There are points of convergence and divergence. The convergences, for example, the long-term and lifestyle impact on patients, families, and society spans across the board of NCD categories. The economic burden, we know that treatment for NCDs is costly, it's long-term, and it has a profound impact on patients. And when the person is a refugee, then that's an added burden. There are other also barriers when the person is a refugee in another country, as demonstrated very well by the previous presenters: language, culture, and economic barriers. But there are points of divergence because the weight of the demand on the patient and family and their own community, the entire society, differs from a patient with cancer who is a refugee versus somebody with diabetes, for example. The financial burden and the cost of treatment is way higher for cancer patients, for sure. And having worked with the WHO, while we were developing the NCD kit for emergencies, some of the challenges we faced, I would like to share with you now, is when you're developing a ready kit, readily assembled, you would want it easy to assemble, you'd want it cost effective, so at a low cost, easy to deliver, that means easy to import, avoiding the red tape and so on. And even the storage conditions, you try to avoid the drugs and medicines that require special storage. So some of the issues you face: cancer medicines are very expensive. If you put them into the kit, then it would inflate the price of the kit. On another level, some of the mental health drugs are mostly falling under the category of controlled drugs. So if you put it there, that means excessive delays, a whole different pathway for importing the kit. And the idea of the kit is to be easy to deliver in cases of emergency en masse. So you'd want to import multiple kits to cover a wider sector of the population. These are some of the challenges and specificities that you need to pay attention to. And finally, the availability of cancer care within the service package of humanitarian organizations is still taking baby steps. And there are lots of hurdles in the referral pathways. Mostly the referral of cancer patients continues to stand as a hurdle in front of humanitarian agencies, including the UNHCR and its partners. And I think we have seen this in the case of Sudan lately with the current conflict. So I will now zoom out and focus on the study we have conducted. It's one of the first projects of the AORTIC Special Interest Group. And we developed a questionnaire through an iterative process. It's a mixed methods study and conducted online with cancer workforce across the continent, rolled out in both English and French. The breakdown of responses, we received around 130 responses attempted. We had to exclude around 50 of them for various reasons, and we ended up with 80 valid responses. The reasons for exclusion were listed here. Some didn't give consent, some were either incomplete or partially incomplete, and a few were from outside the continent. So we had to exclude them for this reason. The majority of the countries, like the highest number of responses was received from Uganda, Ethiopia, and Kenya, followed by a second tier from Cameroon, Nigeria, Burkina, and then a wide array of other countries. The type of health facility where the respondents worked varied between public and private. The majority was public facilities, followed by a mixed type, which is both public and private, and a smaller portion of private facilities. Now, we asked the respondents whether they have provided services to cancer care services to refugees, IDPs, and internally displaced communities within the last 5 years, and it was an overwhelming yes. And when we asked them to specify between either category, whether it's IDPs or people who have crossed the international border, because of course it has bearing on the entitlement when you are a foreigner. And the responses were basically more or less the same in terms of a mix of both, or refugees only, or IDPs, with refugees making the higher percentage. In terms of the numbers of displaced persons who they have served in the last 18 months, the majority of responses fell between 1 to 20 patients, with smaller percentages for above that number. And with regards to the age group of patients treated, again, during the last 18 months, it was basically spanning the age spectrum, more concentrated in the category from 5 years all the way to 65 years. An interesting observation was the very small number of patients above 65. This could have many explanations, maybe the demographic of the population itself, the survival of like the life expectancy in general in Africa of people above 65, but also maybe it hints towards, raises questions about the survival of cancer patients who are above 65 in such setting of displacement. The gender distribution, the majority responded that the patients were mostly female, followed by almost an equal number of males and females, followed by males. Again, this might have to do with the demographic of the population, or maybe they are seeing more female patients. And we know that in refugee situations, men are killed in the war. That's the typical story. Women and children sometimes flee to safety. And from our experience in Sudan with the recent conflict, what we have seen is that the men stay behind and they send the rest of the family to safety. And they end up being caught in the conflict, sometimes just like losing contact for months upon end, and then you don't even know the fate of the previous head of the household. And women who have never worked before or led the family in real terms, in financial terms or economically, are faced with having to lead the family. And these realities are unfolding in the refugee camps right now. Sarah can confirm what they have seen in Uganda, for example. And a friend of mine from Uganda recently said, I noticed that most of the refugees from Sudan are women. I don't know the explanation of that, and we just engaged in such a discussion. Now, moving on, the top 10 types of cancer treated. So the top 5 types of cancer that are seen by the professionals are breast cancer on top of the list, cervical, colorectal, lymphoma, leukemia, followed by prostate, esophageal, liver, eye, and kidney. We inquired about whether the professionals have received training in providing cancer care to displaced communities, and it was an overwhelming no. As you can see, 82.5% said they haven't. And when we asked them whether they have, those who received, whether they have benefited from that training, or even those who did not receive, whether they would benefit from such training, and it was an overwhelming yes. Now, I want to just let you sit with this slide for a bit. These are the reasons we asked those who answered yes, we would benefit from training. We asked them to elaborate, and a number of reasons were quoted. And to me, the most striking feature of this slide is that the focus is not on the clinical aspects, not on the technical, very medical reasons, but many mentioned that the fact that there was emphasis on the fact that refugees and IDPs are a unique population group with very specific needs. Sometimes there is a language barrier, quoted multiple times. There are psychological needs. There is cultural differences between the host population and the refugee population, and the health professionals would like training in communicating, in learning what the pathways for referral are in order to serve this population better and to improve the quality of care and patient outcomes. Now, we inquired about the type of cancer services available in principle, not necessarily for refugees. Available in principle, the least available was radiotherapy. That's for nationals, refugees, everybody. The least available were radiotherapy, followed by diagnostic pathology, and the most readily available was diagnostic imaging, systemic therapy. In the middle stood palliative care and survivorship and cancer surgery. So for nationals, we also asked about the access to cancer services for refugees as compared to nationals. Refugees and asylum seekers were grouped together because they are, as I mentioned, non-nationals. So when it came to refugees and asylum seekers, I think this slide shows something positive, despite the grim picture, which is 52.5% confirmed that refugees and asylum seekers have full access to the full range of services at no extra cost. This was followed by full access to the entire range of services, but at a higher cost, less so, limited access regardless of the cost, limited access because of their refugee status, and then absolutely no access was at the bottom of the range. We also wanted to know whether there is a connect or disconnect between the support provided by NGOs and the health workforce, cancer workforce, providing services to the refugees. And very interestingly, the majority said they are not aware whether there are NGOs serving the displaced population, providing specific support to cancer patients. And I think this is an alarming finding, because it means if the NGOs and organizations exist, the health professionals are not aware of them. And if they don't exist, that means limited support for cancer patients. And either way, this is something that we need to work on, definitely, to bridge the divide. Those who answered yes, they are aware, were asked to list the organizations. At the top came UNHCR and IOM and ICRC and MSF, and then a list of regional and local organizations. When probing further into additional resources, some indicated the majority fell into the psychosocial counseling and support, followed by a combination of psychosocial support plus travel and accommodation, so help with travel and accommodation expenses, followed by exclusively help with like paying the bus ticket for somebody to come, or reimbursing transportation costs and so on, or limited accommodation as provided by my colleague from Uganda, for example, with accommodation, because mostly people come from rural areas to urban centers, sometimes for investigations or to receive treatment, and they need accommodation. And even within Sudan, I recall that the National Cancer Institute in Jazeera State, we had some local NGOs helping people with accommodation. And when the war hit, the people who had already been displaced from their places, let's say somebody coming from Darfur to Al Jazeera to receive treatment, a mother and a child, were double displaced and had to further flee to other parts of Sudan, being rendered internally displaced with no shelter, in addition to having to find new hubs for treatment. Beyond that, there was no additional support provided. So this is also an interesting area where if you just forget about all the detailed modes of cost recovery,
Iman,
this is the case of nationals.
We are a little bit over the time because we want to.
Okay, so I'll wrap up quickly. Sorry about that.
Okay.
In terms of cost recovery for nationals, out of pocket ranked third, but for refugees, it ranked the first, fully 100% out of pocket payment. Some of the limitations mentioned, the most interesting thing is that the limitations are not clinical, they are the cultural, linguistic, and funding. So they have to do with the status of being a refugee more than the details of the clinical diagnosis. Other challenges were also cited, including the security situation and so on. And just bringing it back to the Maslow's hierarchy of needs, where the observation is that the cancer patients who are refugees, their needs and aspirations are kept to the bottom of the Maslow's hierarchy of needs. And this is really painful because people who are in protracted refugee situations can never break that ceiling. And we really need a radical shift in order to do that. Healthcare providers are faced with the ethical dilemma, as mentioned previously. I would like to emphasize on the importance of the referral pathways. And despite the limited government spending on health in the continent overall, I think we have seen a glimmer of hope that refugees and IDPs are provided with care in the majority of cases at no extra cost from nationals. Thank you so much.
This is outstanding, Iman. I am very happy that we are showing our data the first time to the world. There's a lot to think about. There's a lot to, and perhaps we will have another webinar to discuss this data in detail and for the sick. But because we are all running over time and everything was so interesting, I'm just going to go immediately into the panel, and we have Gemma here. Akran, and Gemma is from the Institute of Cancer and Crisis, and in Hong Kong. And so just to go right into it, having heard all of this, and most of it, of course, is not published, and we have very little out there about what's happening in Africa. Gemma, what do you think the international community should do or support the efforts of our SIG or the care for displaced people and cancer in conflict, and what in particular your institute could offer us as well?
Good day, everyone. And first of all, thank you. It's a privilege to be here among such distinguished colleagues today and hear about the great work that AORTIC does. All the speakers, thank you so much. The presentations were really, really enlightening. And as Nazik mentioned, I'm representing the Institute of Cancer and Crisis. It is an independent and non-for-profit organization. And we aim to raise awareness and focus on understanding of systemic cancer, systemic failures that we see during in the critical situations like wars and other conditions. So what the Institute of Cancer and Crisis does, like I want to highlight the first summit that we organized on war and cancer. And because the situations that we have heard today from Dr. Halim, Dr. Makondi about cancer care fragmentation in conflict zones, it's not only the case, it's just the tip of the iceberg. It's not just case in Africa, because there are more than 50 active conflict zones all over the world. And we really, really want to increase the awareness and do as much advocacy as possible to highlight all the issues that cancer patients are facing there, because as it was mentioned during one of the talks, it is a blind spot currently. So we are planning now to organize second summit of on war and cancer together with Institute of Cancer Policy and together with WHO and OncoDaily. And we hope this time to have also on-site event and bring together again, like we did during the first time, key stakeholders and policymakers and people who can really make some real and on-ground changes. So that some palpable changes, because advocacy is good, but it's time for action. So cancer patients will be able to feel difference, and there will be some as I said, some palpable changes that we can witness hopefully in the near future. And for this, I think we need to unite all the forces, and that's what we are trying to do. And that will be the main aim and goal for the second summit on war and cancer as well. And we need to have more representatives from AORTIC to highlight all the specific needs that this region specifically needs.
Thank you so much. I know Ceciltina is here, so we'll also ask her a question. Richard, do you have any questions for Gemma or comments about what before we go to Ceciltina?
No,
I know we're over time, but thanks everyone who's hanging around. We'll try to wrap up soon, but yeah, go ahead, Richard.
with the time, I think this is an amazing group, and I think the as we said when we were in AORTIC at Tunis, first of all getting work published, but also then turning this into real practice and policy change, and that means going to engaging, as Gemma said, World Health Organization, but also UN agencies, African Development Bank. There are a lot of key players, I think, on the continent that will see this as a key area, and it's also good to change the dialogue away from cancer in conflict, where we think so much and talk so much about Ukraine, but this is a completely different ecosystem, and it's important for the global community to understand the diversity. And I think that's what's come over today, is both commonalities but extraordinary diversity that needs very context-specific changes. So yeah, thank you. Back to you, Nazib.
And Ceciltina, so as our new president, and have a lot of connection with all the players in the continent, what do you think? What is your advice for AORTIC? How do you think AORTIC will support us, and also how can we engage with other players in the African scene? This is the African Union and others. So, Ceciltina.
Yeah, thank you, Nazik. And we must to continue to do advocated. Now I am at the Brazzaville WHO meeting, and I will also do some advocated, but has AORTIC and the SIG group can call on member states, the African Union and WHO Afro, to recognize the cancer care as an essential service during humanitarian emergencies, to adopt the continuum of care protocols in national emergency plans, as well to operationalize the rapid response technical support and the funding to preventing avoidable cancer deaths increase. We can do this in various strategy. We can also For the ministers of health, the request should be the integration of cancer care continued clauses into national emergency preparedness plans. For the African Union, the ask should be maybe to adoption of a resolution that recognized cancer care as essential health service in humanitarian and crisis setting, and also for WHO, the focus should be on ensure operational guidelines and establishing and response oncology adversary, and keeping the asks simple and specific makes political uptake more realistic. This is some of my advice, but I have many of advice, like 11 also for us to should form a short and strategic selected coalition with many organizations.
Items on. The presentations were amazing, and each presentation will probably generate like 10 or 20 questions. And so our plan for the next 2 years of the SIG is to perhaps have webinars and engage on like with one country at a time or one issue at a time. So please join the SIG. Please, offer all support you can have. Julie, do you want to say a word?
Yeah, I just wanted to let you know, Nazik, that in the chat there are several people that would like to join the special interest group. So I've got some contacts for you, which I'll pass on to you and Iman as co-chairs. But I also just wanted to raise the idea of having maybe a special issue of the Aortic Journal of Cancer Research, where we can feature each of these stories that have really impressed people here. And get first telling the cancer community about this. As Dr. Songwei said, he'd just not really thought about it before. So let's get the cancer community behind this and then lift it to the right channels. Aortic does have an emerging partnership with Africa CDC, with WHO Afro, and we can raise these issues specifically with them. So I'm very happy to work with this special interest group and get advocates across Africa behind the key messages.
Thank you so much, Julian. So I think before we end, we have heard from all the speakers. I want to thank Julie as VP, Europe for AORTIC, Tina, our new president, and of course, Gemma, thank you so much. We wanted to talk to you more, but at least this is now a new partnership with the Institute of Cancer and Crisis, and of course all the the speakers. Stay tuned for our work, and thank you, Richard, for always supporting us. And of course, thanks to Susie Stanley, who always, I think our first, venture into the world, our first announcement was actually to do the London Global Cancer Week last year, and look how far we came in 1 year. We have now our own data to present, and so many new, voices from different countries. So with this, I think I will end here. You have our contact, and please don't hesitate to contact us. And thank you so much, everyone, for staying over time and for everything.
Thank you so much, Nizzy. I'll be to see everyone.
Thank you so much, everyone. Bye.
Thank you. Bye-bye.
Thank you.
Thank you all. Bye.